Good evening, everyone. Today we are going to discuss about intestinal obstruction differential diagnosis and management, which is one of the most important topic for UG and PG both, especially for PGs. I'll start with the classification. Intestinal obstruction can be a dynamic and adynamic. What is dynamic obstruction? It is a physical obstruction of a flow or of a feces. And adynamic is no physical obstruction, but wall is not contracting. The peristalsis is absent. And because of that, the content is not able to move ahead. In dynamic, there is something which is obstructing food particles or bowel content to go ahead. So that is the big difference. So there are the different causes of dynamic and adynamic obstruction. In dynamic, we can divide it into the intraluminal, intramural, and extramural. What is intraluminal? So something, if there is something which is inside the lumen of a bowel, which is obstructing to food content to go ahead, that is intraluminal. That can be the fecal impaction or any foreign body or bezoar. That can be a trichobezoar or something, a gallstone. Then intramural. Intramural means there is something in the wall of a bowel, in a not inside the bowel, but in the wall of bowel. So that is intramural. So stricture, malignancy, intussusception, and volvulus can be intramural. Stricture, you must be knowing in tuberculosis or any Crohn's disease or typhoid and other diseases can cause the stricture. Malignancy, the bowel wall will, the growth will be starting from the bowel wall. So that is called intramural. Extramural is outside the bowel, but causing obstruction due to any closed loop obstruction or any, like in hernia, there is a ring, deep ring and superficial ring, the bowel content is coming out of it, and that is, a ring is small and content is coming out, and now it is not able to go inside, go back in the normal place. That is, and causing obstruction, that is extramural obstruction. And now another is adynamic obstruction. Adynamic means, as I said before, there is nothing inside the lumen, and now there is something due to the absence of peristalsis, like into the paralytic ileus or in the pseudo obstruction. Another classification we can do as per site of obstruction. So it can be a proximal small bowel obstruction, distal small bowel, or a large bowel obstruction. So in a proximal small bowel, we include duodenum and jejunum. In distal, it is ileum, and in large bowel, anywhere in the large bowel, in large intestine, from cecum to ascending colon, transverse colon, or descending colon. So if we are thinking about a small bowel, proximal small bowel, what things can be included? It can be due to the congenital causes, any lipoma of small bowel or leiomyomas, malignancies, bends and adhesions can cause a proximal small bowel obstruction. In distal small bowel, tuberculosis most commonly involves the ileum. So tuberculosis, malignancy, Crohn's disease, gallstone ileus, if you remember. The hernias commonly involve the ileal part, which is near to the inguinal ring. A roundworm infestation in the any congenital conditions. And in large bowel, you will see most commonly a malignancy causing an obstruction. After that, a tuberculosis, any anorectal malformation, volvulus, congenital megacolon, and bends. So what will be the clinical features? It will be according to the site of involvement. Like if it is a proximal small bowel, then the vomiting will be the first symptom, as the food won't be able to pass from the duodenum itself. So as patient will eat, he'll have vomiting. So he'll have severe vomiting. Due to vomiting, fluid loss, he'll be having dehydration. Or no or less distension, as there is no distal obstruction, so there is nothing, no place for the any content to stay inside the abdomen, so there won't be any prominent distension over the abdomen, and colicky pain will be there. So in distal small bowel, there will be central distension, vomiting will be there, but it will be slightly delayed than the proximal small bowel. Dehydration will be again there, and central abdominal pain will be there. In large bowel obstruction, you will have constipation and distension more than the vomiting. Vomiting will be very late feature, as there will be some obstruction into the large bowel. Content can go up to the large bowel, and as it can fill in up to the stomach, it will have a delayed presentation. It will have a large amount of big distension there. Peripheral and central both distension will be there, right? And vomiting will be late when there is a full intestine is involved. What are the special features on the plain X-ray? By which you can differentiate this three. It is if it is a small bowel, distal, proximal, or a large bowel. So valvular connivence will be present in the small bowel. Characterless central fluid level seen in the distal small bowel, whereas dilated haustration will be seen in the large bowel. Another classification can be according to the congenital or acquired. So anorectal malformations, congenital megacolon adhesions, duodenal atresia, ileal atresia, jejunal atresia, any other bands and adhesions like patent vitreointestinal duct or something, malrotation, volvulus neonatrum. These are the congenital conditions. In acquired, it will be hernia will be the most common. Postoperative intussusception, roundworm infestation, gallstone, tuberculosis, malignancy, and internal hernias are acquired causes of obstruction. Bolus, if there is something inside the lumen, that can be a bolus also. So which bolus can cause obstruction? So worm bolus, gallstone bolus, trichobazar, phytobazar, meconium pellets, foreign body, food bolus, and stercolits. These are the bolus which can obstruct the lumen and cause the obstruction. Here I have shown the diagram which is showing the pie chart of common causes of intestinal obstruction from most common to least common causes of intestinal obstruction. So nowadays adhesions are the most common cause of intestinal obstruction. Other are the obstructed hernia, inflammatory conditions, carcinoma, fecal impaction, as I said before, and pseudo obstruction. So what are the cardinal features of the intestinal obstruction? What features, what complaints patient will bring when he is coming with the intestinal obstruction? So that will be the abdominal pain most commonly. Another is the vomiting, abdominal distension, and no passage of feces and the flatus. This thing you can easily understand that if there is a obstruction and intestinal bowels are getting distended, patient will have, first of all, its bowel will try to release the obstruction. So there will be the high peristalsis that will be causing colicky abdominal pain. If it is a proximal or proximal obstruction, there will be the vomiting also, as I said before. Due to dilatation of bowel to accommodate the content, there will be the abdominal distension, and there will be no passage of feces and flatus distal to the obstruction, right? That is complete obstipation. So what is the pathophysiology behind or factors causing systemic problems in case of intestinal obstruction? So there will be, I have one figure here. There will be the distal, if there is obstruction here, something is blocking this pathway. So there will be the content which will try to accommodate over here, this side, proximal to the obstruction site, and it will cause dilatation of the proximal loop, and distal loop will be the collapsed one. So dilatation of the bowel, decreased absorption across the mucosa, increased secretion into the lumen, intramural inflammation and hypoxia will also occur, increased intraluminal pressure secondary to all this above situation. Later on, venous congestion and increased venous pressure will occur. After that, disruption of the mucosal barrier occurs, translocation. And at this stage, patient will go into the systemic inflammatory reaction, and patient can also go into the modes also, multiple organ failure also. So this decreased absorption across the mucosa and increased secretion, which will lead to the electrolyte imbalance, and fluid retention will also cause the fluid imbalance also. And due to the collection of the fluid inside the proximal loop and gas and fluid collection, there will be the air fluid levels due to these things, decreased absorption, increased secretion into the lumen. This will cause air fluid level inside the bowel loop. So what will be the change proximal to the bowel obstruction? There will be the obstruction which will cause intestinal increase into the peristalsis. As I said before, the bowel will try to release the obstruction, and for that it will increase the peristalsis, which will gradually become vigorous, And after that, if even after this gradual increase in vigorous peristalsis, if bowel obstruction is not relieved, peristalsis become gradually taper down and it will ceases by the time. And after that, fatigue will occur into the bowel wall. That will cause placid, paralyzed, dilated or bowel loop. Right. What are the changes at the site of obstruction? At the site of obstruction, initially venous return will be impaired. Due to, in this figure, you can see here it is the obstruction. It won't, there is inflammation and other changes will be here. So venous return will be, first of all, venous return will be decreased. After that, congestion, edema, as venous return is decreased, congestion, edema of the bowel wall will occur, right? Because of that, purplish hue will be present over the bowel loop. Later, after this, that will jeopardize the arterial supply. Once venous supply will be blocked, there will be congestion, and after that, arterial supply will also be included. So, a loss of shininess and blackish discoloration will occur now, and peristalsis will be absent now. And once the arterial supply involved, there will be gangrenous changes will be present. Once gangrene will be settled down, perforation will occur. And after perforation, bacteria and toxin can migrate into the inside the peritoneal cavity, which can lead to the peritonitis. Here I have shown the figure, the gangrenous loop. If it will perforate, the content will come out through this perforation and it will cause peritonitis, generalized peritonitis. This is one side obstruction. In this is the closed loop. This is the figure of the closed loop obstruction, in which there is a competent ileocecal valve. There is nothing deformities over here. There is a mass over here, like this. But here, what happens? Here there is competent ileocecal valve, so it will bring content inside. It won't allow content to go back to the ileum. So content is coming here, but it is not able to go ahead from this side, from this growth. So there will be the closed loop obstruction. From here and here, it will be blocked. So content will be accumulated over here. That will cause, due to gravity and the lowest part, circular ulcer will be present over the cecum. Right? This is closed loop obstruction. Similarly, if there is a hernia in that both the loops are coming outside from this ring, and the ring is tightened and content is not able to reduce, then it can also lead to the closed loop obstruction, in which proximal bowel loop and the distal bowel loop both will be collapsed, both will be emptied, but this the closed loop will be dilated. So these were the clinical features and pathophysiology of obstruction. So after that, we will go to the investigation. What are generalized investigation we will need in the case of obstruction when we are suspecting an obstruction? So first of all, the basic investigation will be the X-ray abdomen. The erect posture and supine posture, both are important. In erect posture, what we will be able to say is multiple air fluid levels. We will be able to see multiple air fluid levels. If there are more than 3, then it will be significant. Why? Because basic 3 will be seen, like in the stomach, duodenum and jejunum. It will be normal air fluid level, which will be present in each cases. So we cannot consider it. If it is 3, then it is normal. But if it is more than 3, then it will be the intestinal obstruction. In supine film, all over the abdomen is involved with the multiple air fluid level, we can think about a large bowel obstruction, right? So what are the specific features on the AXR? AXR means abdominal standing X-ray. So if it is jejunum, then concertina effect will be seen. Step ladder pattern will be there of air fluid level. Complete valvuli will be seen, and feathery appearance will be there. Like here I have shown, this is small bowel obstruction. So there is complete valvuli will be there. Step ladder pattern will be there. Concertina effect will be there, right? Whereas in large bowel, hostrations are not a complete ring. You will be able to see, if you can see, there is not a complete ring, but there is a partial ring is here, and peripheral also involved with the central part. Here it is only just central. Here is a peripheral and central multiple air fluid level. Whereas if ileum is involved, it is called as a featureless loop of Wegenstein, as there is no specific significant features will be seen as it's seen in the jejunum, or as a featureless loop of Wegenstein. If large bowel is involved, there will be hostrations and presence of peripheral air fluid level on the AXR, as I shown. Right? So this was the basic first investigation we will do. After that, USG abdomen we will do. Why? In children, USG abdomen is investigation of choice. It will show the dilated bowel loops. Site of obstruction can also be diagnosed with the help of USG. Peristaltic movement can also be appreciated on the USG abdomen if it is present or absent. On CECT abdomen, it is investigation of choice for the adult nowadays to rule out any malignancy, a site of a transition point in the obstruction case. In adults, especially, we are doing CECT. In that also, we can appreciate the multiple air fluid levels, site, and cause of obstruction can be identified. So these are three basic investigations. That once we are examination is obstruction in our, we have to immediately start resuscitation. As I said, in pathophysiology, there will be the fluid loss, and due to decreased reabsorption of a fluid and increased secretion in case of obstruction, there will be the third space loss in the patient, and electrolyte imbalance will be there. So we have to correct this third space loss and prevent the dehydration, and we have to correct the electrolyte imbalance. So for that, ringer lactate will be the best fluid, as patient will be into the hypokalemia and hyponatremia, and RL will be the best solution to correct that. With the IV fluids, we will have to insert the Ryle's tube immediately to, first of all, to decompress the bowel, and secondly to prevent the aspiration while patient is vomiting. We have to give IV antibiotics to prevent the sepsis in patient. In case of perforation or not, no matter what, we have to give antibiotics, as we are going, if we are planning for the operation, or if there is to prevent any secondary complication, to prevent patient going into the sepsis. And IV analgesics for the pain management. And with that, we have to monitor the patient. While monitoring and resuscitation, if patient improves, we keep patient conservative. Most commonly in patients with the postoperative adhesions or paralytic ileus, patient will improve, and we will keep those patient on the conservative management. But in other cases, like into the malignancy or any secondarily, like due to the atresia or any other causes, patient won't be improved even after resuscitation. So in that case, we have to go for the surgical management. So what surgical management we can do? There are 2 points. A diagnostic laparoscopy we can do, and exploratory laparotomy we can do. Diagnostic laparoscopy we are doing in cases where we are not getting a time to get the CT scan done due to any causes. We approach for the diagnostic laparoscopy, and in cases where we are knowing that the exact cause for the obstruction, we can approach for the exploratory laparotomy. So where we are jumping for the immediate exploratory laparotomy. So there are 3 causes, most important causes, where we are not waiting for patient to get into getting recovery with the resuscitation only. So strangulation, perforation, and peritonitis. In these 3 cases, if we are suspecting these 3 things, we are jumping for the immediate exploratory laparotomy with the resuscitation. So now, after this generalized symptoms management pathophysiology, we will go to the specific causes of the obstruction. So first of all, we will discuss about the adhesions, which was the most common cause overall for the obstruction, most commonly seen into the small intestine, and most commonly seen after the surgery, post-surgery. That is obvious. Everybody knows that after any surgery due to manipulation of bowel, peritonitis was present. The chances of adhesion will be increased. Pelvic inflammatory disease, post radiotherapy, the non-surgical cause for. What will you be able to see is obstruction. So multiple air fluid levels will be there. If small bowel, then central air fluid level. If peripheral and generalized, then it will be the large bowel also involved. Here you can see the multiple air fluid level, right? So what are the study can help it diagnostic as well as therapeutic in these patients. These patients can be kept on the conservative management for 48 to 72 hours, as majority of them recovers in this duration of a time. If not improve, we have to do laparotomy and do adhesiolysis. And Charles plication to prevent the adhesions post-surgery. Nobel's plication, in which we are plicating the bowel, a small bowel we plicate to prevent the adhesions in a later stage. And in Child's Phillips, we are plicating the mesentery. So to prevent the post-surgery secondary adhesions. What are the other preventive measures to prevent the adhesions? So instilling drugs like a hyaluronidase, steroids, dextran, dextrins, polyvinyl silicon, fibrinolysins, chondroitins, and streptomycins. This can prevent the adhesions. Gentle handling of a bowel, prevention of spillage of content like a bile and feces, ideal peritoneal wash during using 8 to 10 liters of saline before closing the abdomen, and careful placing of a drains, and laparoscopic procedures has got a lesser chances than the open laparotomy method to prevent the adhesions. These are the points which we have to keep in our mind during doing any open surgery. This is also one of the prevention. In few cases now much, but that previously. So this was about the adhesion. So another is bowel atresia. So bowel atresia obviously will be seen into the children's most commonly. So there are small bowel atresias more commonly seen. That can be the proximal and distal. If proximal, then it will be duodenal or jejunal. If distal, then it will be ileal atresia. So duodenal atresia will be the most common of all the atresias. It will be associated with the Down syndrome, polyhydramnios, and annular pancreas will also be seen with this duodenal atresia. So what will you be able to see in the duodenal atresia? There will be the double bubble sign. If atresia is here, one gas of the stomach will be here, one is of duodenum here. Distal it is obstructed. There is atresia. There is no third gas will be present. So double bubble sign will be there. Just two bubbles will be there. Two air fluid levels will be there. So what are the types of duodenal atresia? It can be the complete atresia with the separation. There will be no connection in between, right? There can be type 2. In type 2, there will be the fibrous cord will be present. In type 3, duodenal atresia partially it will be connected. And in the type 4, there will be the windsock deformity, in which there will be the small thin mucosa will be there, which will be obstructing this pathway of second part of duodenum. So there are 4 types of duodenal atresia. So there is obstruction somewhere here in the second part only. So what will be the treatment? Just think logically. We have to connect these 2 parts, right? We have to just simply connect this 2 part, either directly, either by resecting this windsock deformity or this fibrous bend, and or directly we have to connect in such complete atresia. So this is the treatment. We are connecting this part and call as a duodenostomy. Kimaru's operation most commonly done, Kimura's operation, sorry. Or if large part of a duodenum is involved, then we have to do duodenojejunostomy. So on upper part, we are putting the transverse incision. In lower part, we are putting the vertical incision. Diamond shape, we will stitch both the part, and that is called as a Kimaru's anastomosis, right? This was about the duodenal atresia. Now, if distal part or jejunum is involved, then it will be jejunal atresia. It is more common than the ileal atresia, associated with the cystic fibrosis again, and malrotation of gut is also seen in few babies. In this case, you will be able to see triple bubble sign. One in stomach, one in duodenum, one part in jejunum. Distal to jejunum, there won't be any bubble. So it will be triple bubble sign in here. So again, what will be the treatment? We have to resect the part which is obstructed, and we have to anastomose the bowel. So there are the four types basically here in the small bowel. In type 1, there will be the mucosal atresia. There will be the mucosal atresia here. In type 2, there will be the fibrous band connecting to the part of a bowel, a jejunum. Part of a jejunum will be connected with the fibrous band. Most commonly, type 2 will be seen. In the third type, there will be a V-shaped mesentery. So there won't be any connection, fibrous connection, completely aparted, and V-shaped mesentery shape will be seen, complete single. In type 3B, there will be the complete jejunal atresia with coiled ileum will be present. It is also known as apple peel atresia. Jejunum will be just a small part of artery will be supplying the ileum, and that will be the Christmas tree-like appearance over the of the ileum. There won't be any connection between ileum and jejunum, right? In type 4, there will be the multiple atresia in between. Like in type 2, the type 3A, there was single V-shaped mesentery. In type 4, there are multiple V-shaped mesentery, V-shaped atresia will be present, right? Which is least common. So treatment will be resecting this part and joining this part, called as a resection, and anastomosis, simple. After the atresia, the meconium ileus, most commonly we are facing in pediatric patients. So it is most common neonatal bowel obstruction cause for the bowel obstruction. It is associated with the cystic fibrosis. We are doing in such patients, we do the sweat chloride test. What will be the clinical features in such patients? There will be complaint of no passage of meconium in first 24 to 48 hours, and abdominal distension will be there. After birth, he or she, the child, won't have passed the feces. Not we can't say feces, but meconium. On AXR, there will be the soap bubble appearance. It is known as Neuhauser's sign and microcolon. Gelatin X-ray film will not get digested by the patient's vomitus. In this, we do such test. We use the X-ray film, which will be of gelatinized. If vomitus, there will be the high chloride in such patients, and that will cause it will prevent the gelatin to get digested by the patient's vomitus. Normally, if we are putting our vomitus, it will get digested. X-ray film, the gelatin will be digested by our vomitus. What will be the management of this patient? First of all, we try the conservative before operating the patient. So what will be the conservative management? It will be the gastrographin enema, first line of management. If it gets relieved by the enema, then it will be best. If not, then we have to go for the surgical approach. So what surgical approach will be there? That will be the Bishop-Koop surgery. In that, we are doing end-to side ileostomy with irrigation stoma. So for understanding this thing, we must know the pathophysiology. In this case, in the child with the cystic fibrosis or just meconium ileus, there will be the viscid meconium accumulating over this side, over this proximal ileum. The pellets of meconium will block this distal ileum, the IC junction, and the part of a cecum. So these pellets will block this whole pathway. So it won't let the feces or meconium go ahead to the distal part. Right? So narrow collapsed colon will be there, and pellets will be seen into the cecum and distal ileum. And proximal ileum, there will be the viscid meconium. So to move this, we use the gastrographin first. So even after gastrographin, if it is not it is not shifted, it is not resolved, the meconium ileus, then we have to do what we have to do. We have to resect the part of this part. We cut this ileum from this side. We do the end to side, the cut part of ileum, we will connect this part here, one part of ileum here, the cut part, and one part we will bring to the abdomen for the ileostomy, for the irrigation, right? So we will irrigate, a stool will come over here from here, and we can irrigate also from this side. So it is called as a Bishop-Koop surgery, end to side ileostomy. One is on the end of ileum, and one is on the side of ileum, and one end is on abdomen. So this was about the meconium ileus. After that, intussusception. In 1 to 3 year old children, and even in the adults and old patient, we are sometimes able to see this intussusception. What is intussusception? So it is simply a bowel within bowel, telescoping of one portion of bowel into the adjacent segment. That is, a proximal bowel slips into the distal one, antegrade. But in rare cases, so what are the case? That is the retrograde intussusception seen in the operated case of Roux-en-Y gastrojejunectomy. Here, this is the intussusception. This is the part of intussusception. There are three parts. That is intussuscipient. It will receive this intussusceptum part, right? And this is a neck of intussusception. This is the apex, where the most common ischemic changes will be seen in the apex part, where the bowel is going inside. The proximal one is coming into the distal one, right? So here, neck will be the narrowest part, but ischemic changes will be seen over here. The snake is narrowest, the small diameter, but changes will be seen here as it is inside. And because of ischemic changes over here, you will be able to see current jelly stool in the in a stool due to the ischemic changes over here and bleeding from this side. So the intussusception can be primary or can be secondary. Primary intussusception commonly seen between the 6 months to 2 years of child. Pathophysiology most commonly is due to the hypertrophy of POS patches in the ileum. So ileocolic is most common overall intussusception presentation. Secondarily is secondary name itself suggests that due to any secondary leading point, if intussusception occurring, that is called a secondary. So commonly secondary will be seen in the adults. So most common leading point is polyp in adults, followed by Michel's diverticulum and tumor. In children, leading point will be polyp or tumor. Secondary will be colocolic commonly and recurrent. So most common will be ileocolic only, but if secondary, then it will be colocolic. What are the clinical features of intussusception? If patient is coming with intussusception, how will we be able to differentiate it from the other causes? So in case of intussusception, child draws up his legs while crying. He'll cry inconsolably and he'll draw his legs up, right? And current jelly stool will be pus, as I said before, as pathophysiology itself suggests that there will be current jelly stool. There will be sausage-shaped lump in the around the umbilicus due to this proximal goes into the distal and forms the sausage-shaped mass. It will be around the umbilicus. Concavity will be the towards the umbilicus. RIF will be empty. That is called a dance sign, right? Empty RIF, and there will be sausage-shaped swelling around the umbilicus. Rest same as the cardinal features as we have discussed before. The other features will be similar as the generalized GI obstruction. That distension, pain, vomiting, those features will be same in this patient only. So differentiating feature will be this only. Child will drop his leg and cry inconsolably, current jelly stool, and sausage-shaped lump. So what will be the specific investigation, specific points will be able to see into the investigation? So in AXR, in this patient with the air fluid level, we will be able to see the claw sign, pincer sign. You can appreciate this is the claw. This claw due to proximal bowel is going into the distal one. The contrast will show the claw-like appearance here. That is called as a claw sign on the AXR. On the USG, there will be the donut sign, a target sign. If you know the donut or target, there will be the bowel within bowel. So one round outside and another round inside. That will show as a donut. So that is donut sign or a target sign. Pseudo kidney sign will be there due to mesenteric vessel into the bowel loop. Investigation choice for the child is USG, as I said before, and for adult, if you are suspecting intussusception, the investigation choice will be CECT abdomen. So what management we will do for the intussusception patients? So first of all, we will try conservative. That is contrast enema we will give. That will be diagnostic and therapeutic also. Under fluoroscopic vision, barium, air, or warm normal saline instillation can also be used for the conservative management of intussusception. So as we are giving a barium enema or air, we are pushing air. What it will cause? It will push from distal part, it will push the proximal bowel ahead, and it will relieve the intussusception. But even after this conservative management, if intussusception is not getting relieved, or if it is occurring recurrently, then we have to go for the surgery. So indication for surgery will be recurrent episodes, secondary to the pathological leading point, perforation and strangulation. Perforation and strangulation we have discussed already before. Secondary leading point is important, as if there is secondary leading point is there present, and if we are not removing the point which is causing the we will milk the bowel and check for the viability of a proximal loop. And if it is not viable, then we have to go for the resection and anastomosis. Here I have shown the method of milking from distal to proximal loop come out. Right? This was about the intussusception. After that, in adults, we sometimes see the case of obstruction with the volvulus, large distended abdomen. The volvulus will be most commonly seen in the adults. So what is sigmoid colon will be more commonly involved than the cecum. So sigmoid will be, there are the predisposing factor for the sigmoid volvulus. What are the predisposing factors? So that are the long and narrow mesentery, redundant sigmoid, loaded sigmoid colon, and patient with a psychiatric illness. In these cases, you will able to see the sigmoid volvulus more commonly. This volvulus, in case of volvulus, it will rotate anti-clockwise more commonly than the clockwise. Right? Bowel will move anti-clockwise, not clockwise. That is more common presentation. What are the clinical features? Marked distension will be there. Not the as you will be able to see in the normal obstruction, it will be comparatively so. Investigation AXR, what we will be able to see in closed loop obstruction. So dilated loop will only be seen here. Only the loop inside will be seen as the dilated one. Hello?
Hello, ma'am. Actually,
coffee bean appearance.
So sorry to disturb, but the voice is breaking. Ma'am, I think it says here that your bandwidth is low. Could you just switch off your video, because sometimes that helps with the connection.
Yes.
Yeah, thank you.
So now are you able to listen?
Yes, ma'am, it's better now.
So I hope the volvulus haven't missed.
Ma'am, it was fine. It just broke a couple of times in between, but it seems much better now.
Okay. So in investigation, there will be coffee bean sign will be there. Due to closed loop obstruction, dilated loop will be seen like a coffee bean, right? Bent inner tube like, or omega sign, you can say this coffee bean or bent inner tube or omega sign you can see in the AXR. So in contrast study, there will be bird beak appearance or on a SPED sign will be seen. See, if it is child, then investigation choice will be again USG, and for adult, it will be CACT. So what management we will do for the case of volvulus? So if patient is stable, we can try for the sigmoidoscopic decompression as an emergency management. And for definitive management, we have to do sigmoidectomy or sigmoidopexy as a definitive management. But sigmoidectomy is more preferable. Ischemic changes later on. So we prefer sigmoidectomy more. In case of unstable patient or there is strangulation or colostomy with Hartmann's procedure. followed by secondary colocolic anastomosis after the 6 weeks. What we are doing is we resect the part of volvulus, hold the sigmoid, descending colostomy in such cases. Descending colon will bring out on the abdomen and do descending colostomy. And we will close the distal bowel loop at the first in the first procedure, first part of operation. And after 6 weeks, we will do colocolic anastomosis in the second part of operative intervention. What other management we can do is Paul Mikulic's procedure. In that, we don't close the distal part. We just bring both the part outside, distal as a just mucous fistula and proximal as a the stoma, the proper stoma part, which will take out the fecal output. We just resect the sigmoid colon with the obstruction and we bring both the loops outside, right? That is called Paul Mikulic's procedure. This was about the management of a sigmoid volvulus. Other is a cecal volvulus. Cecum can also get volvulus. It is due to the mobile cecum. It rotates clockwise more commonly. In sigmoid colon, it rotates anti-clockwise more commonly. Cecum will rotate clockwise. On AXR, we can see the apex. But if cecum is involved, if it is get rotates and if get distended, its loop is get distended, its apex will be on the LHC side. It will go on this side, on LHC side, right? That will be the difference. Again, there will be coffee bean appearance, same, but the apex will be on the LHC. The small points are important to differentiate this different DDs. So investigation of choice for CCT will be there. It will be most useful. In management, if stable patient is there, then directly go for laparotomy and we do right hemi. In case of compound volvulus, iliosigmoid noting will occur. In that case, we have to remove anastomosis or SO. Other causes for the intestinal obstruction are malrotation. If there is a malrotation in development, then it will present as an obstruction at times. In first stage, if it is getting malrotated, if in first stage, if deformity occurs, that will be present as an exomphalos. It can be major or minor, or it can present as a gastrochiasis. In second stage of development, if error occurs in the rotation, that is the exact point of rotation. In this stage, rotation, that is it is not rotating at all, it is not going back to its normal site at all, so that will be the non-rotation. Incomplete rotation means it will rotate partially, so it is most common type of malrotation, and in that case cecum will be located into the subhepatic right hypochondriac region. In that case, large peritoneal band will connect from cecocolic loop to the posterior abdominal wall, which will compress the second part of duodenum. An entire midgut is hanging down along with the superior mesenteric artery as it is not rotating and going back to the normal site. I'll show a figure in the next slide. This is about non-incomplete rotation. Sometimes reverse rotation occurs. Final 180-degree rotation, in that time, it occurs clockwise, bringing the colon posterior to the duodenum and the superior mesenteric artery. But in reverse rotation, what will occur? It will comes anteriorly, right? It won't go. It won't go posterior to the duodenum. It will go to the posterior to the duodenum. Sorry. In another is hyperrotation. In hyperrotation, rotation occurs up to the 360 to 450 degree beyond the normal rotation. It will go up to the 450 degree. It will cause cecum go into the left side of abdomen and encapsulate the small bowel. Encapsulation of the small bowel occurs while the fetal midgut returns to the coelomic cavity. This was about the malrotation. And if mal error occurs into the rotation in the stage 3, in the final stage, in the last stage, then final defect in the fixation causes the mobile cecum. It won't be fixed and mobile cecum and ascending colon, it will lead to the cecal volvulus, right? Here I have shown the figure. This large bend will connect the cecum here. It won't let cecum to placed into the RIF region, and due to that, whole small bowel will hang with the superior mesenteric artery, and that can cause as whole below. What it will cause? It can cause the volvulus secondarily. So in such cases, in such case of incomplete rotation or non-rotation or malrotation, we have to release this large bend. We have to do appendicectomy, and we have to place this, straighten this small bowel and colon. So it won't get malrotate, it won't get volvulated. Here it is coming from behind, from the transverse colon, coming this side and going this side. We just release this band, we cut this band, we take this cecum to the right RIF side, or to the opposite side. We do appendicectomy and we straighten this loop of duodenum, right? That is called as a Lard's operation. We release the duodenum, so obstruction will be released. That is called Lard's operation, as we are cutting the Lard's band. So what is the other what are the other causes? That are the stricture. As I said before, stricture will be seen in the tuberculosis, Crohn's disease. If there is a single stricture, we do manage patient according to the number of stricture, if say it is single or multiple. If single and involve multiple but involving a small part, we can do the stricturoplasty. Or if there is a long segment of stricture is involved, we have to do resection and anastomosis. Other causes of obstruction will be obstructed inguinal hernia. We go for the further management. In case of diaphragmatic hernia, if the bowel has gone upside due to rent into the diaphragm, we just take the bowel inside the abdominal cavity. We check for its patency. If it is viable, if bowel is viable, we do not do anything, and we just close the diaphragmatic rent, and we keep a drain and close the abdomen. If the bowel is not viable, if it is it has got gangrenous changes or necrosis, then we have to do resection and anastomosis with primary repair of diaphragmatic rent and putting the ICD on the diaphragmatic rent side. In case of worm infestation, if perforation or peritonitis has been settled down, we have to do resection and anastomosis if bowel is not viable, and if and we have to remove out all the worms from the perforation site as much as possible. We usually do, if there is no perforation has settled down and worms are in the small bowel, we just milk out them to the large bowel. We put them into the large bowel and close the laparotomy. We just wait and watch for that. And if, as I said, if the bowels are not viable and involving the large bowel, we have to do resection and anastomosis same. And we have to give antihelminthics in such cases like albendazole. As we discussed before, with the dynamic, there is adynamic obstruction also. Adynamic, again, paralytic ileus and pseudo obstruction are the most common presentation of adynamic obstruction. In case of that, in that case, what will be the clinical feature? There won't be a colicky pain. Why? In case of dynamic obstruction, there was something obstructing the lumen, and to release that obstruction, the bowel were giving the hyperperistalsis, and that was causing the colicky type of pain. But in this case, there is nothing to obstruct. Be there like a distension, vomiting, right? Rest will be the similar. So investigation of choice, again, first slide, that CACT abdomen for the adults and USG abdomen for the children's. Management will be conservative in most of the cases, but if patient doesn't improve in 72 hours, we have to need to take patient for the surgical intervention. Specifically, ileus have been settled down. So there are many causes for the pseudo obstruction. Paralytic ileus is a part of a pseudo obstruction. So what are the factors causing pseudo obstruction? That are the metabolic causes: diabetes, hypokalemia, uremia, myxedema, intermittent porphyria, or any severe trauma, especially of lumbar spine or pelvis spine, which is involving the nerve supply or of the bowel, can cause the secondary to pseudo obstruction. That is not a true obstruction. That is pseudo, temporarily due to any secondary causes. That is a pseudo obstruction. Or a case of a shock like burns, myocardial infarction, stroke. Blood, urine, enzymes, and tumor. In case of hemoperitoneum or so, there can be a secondary due to irritation. There will be the paralytic ileus causing a pseudo obstruction temporarily. Drugs like laxatives, phenothiazides, and tricyclic antidepressant can also cause as a paralytic. Say we discussed before, we do conservative management. If patient doesn't improve, we have to take that patient for the open laparotomy, right? This was all about the important causes, important differential diagnosis of the obstruction and its management. If you have any other queries, you can put into the chat box or you can put into the YouTube comment section. I'll reply accordingly.